Hello, I'm Dr. Nimish Vakil. I'm a gastroenterologist in Wisconsin. I serve on the faculty of the University of Wisconsin Medical School and work at Advocate Aurora Healthcare. I'd like to talk to you today about our study entitled Multitarget Stool DNA Testing for the Prevention of Colon Cancer Outcomes in a Large Integrated Healthcare System that was just published online in Gastrointestinal Endoscopy. Let's start by discussing why we did the study. Our study originated from observations in clinical practice. Over the last few years, we have had patients referred to us for colonoscopy after a positive stool DNA test obtained for colon cancer screening. We were struck by several findings. First, the patients had a limited understanding of the test. Some thought the stool test was equivalent to colonoscopy, and many patients were unaware that the stool test needed to be repeated at 3-year intervals. We were also struck by the number of examinations that showed no pathology in patients with a positive stool test or showed a small adenoma. We reviewed the literature on the test and found that there was very little published information on the use of the stool DNA test in routine clinical practice. This brings us to our first point about this study. This is an effectiveness study. In contrast to the efficacy studies performed under careful circumstances in randomized controlled trials, effectiveness studies are performed under routine clinical conditions. This is because life outside controlled trials is messy, and the true value or limitations of a test or a therapeutic strategy become evident in an effectiveness trial. The study was performed in a large integrated healthcare system comprised of 15 hospitals and 150 outpatient clinics with a diverse population of patients and physicians. We used a cloud-based data capture system called REDCap, developed by investigators at Vanderbilt University to facilitate customizable database research and extract information from medical records. To enhance the accuracy of the data, the records of every patient were manually checked and the histology of polyps was verified from pathology reports. We performed a cost analysis using the published cost of the test and report costs to an organization considering implementing stool DNA testing as a strategy to be applied for colon cancer screening in a population. Our design was deliberately observational so as not to interfere with the outcome of the study. We did not influence selection of the screening test chosen or intervene with regard to follow-up procedures after a positive stool DNA test. In this paper, we report the results of 1,242 patients who had a positive stool DNA test. Only 89% were referred for colonoscopy and 73% underwent colonoscopy. This was an important and unexpected finding in our study. A positive stool DNA test result is reported to the primary care physician, where subsequent action depends on local practice. Nursing staff typically contact the patient and refer the patient for colonoscopy. Once the referral is made, the patient is contacted at least 3 separate times by telephone and by letter until the procedure is scheduled. Some patients in our study were not referred for colonoscopy. Others were referred but never scheduled despite multiple reminders. And finally, there were patients who were appropriately referred and scheduled but canceled and never rescheduled the procedure. We allowed a long follow-up period of 1 year to ensure that the procedure never took place. There are several issues to consider here. One is a process issue, making sure that in a 2-step process, such as stool testing for colon cancer prevention, that the second step gets done. This may need institution of processes that are triggered after a positive stool test, much as they are after a referral for open access screening colonoscopy. For example, if we receive a referral for screening colonoscopy and the patient does not return calls or respond to requests to schedule, by telephone and letter, the primary care physician receives a message that the patient has failed to schedule. Some healthcare systems use navigators to facilitate communication and scheduling, but this is only possible in large systems and adds cost to the strategy. The behavior of some patients who chose a two-step screening process but refused to perform the second step deserves some comment. A lack of understanding of the significance of a positive test is a possible explanation, but it is also possible that some patients who choose what they perceive to be a simple test are ill-suited for a multi-step strategy. Choosing the right test for screening for a patient requires a commitment of time to discuss the options and personalize the choice. In this regard, guidelines that provide a laundry list of available options and suggest that any screening is better than no screening may confuse some patients. An analogy may help clarify this. It is clearly better to eat junk food or tinned meat than to starve, but if fresh food is plentiful and affordable, neither of these choices makes sense. Guidelines should provide a considered analysis of options that leads to the correct choice of a test for a given patient. Our results for the detection of adenomas and cancer are calculated by intent-to-treat analysis. An analogy may also help explain why it is important to use intent-to-treat analysis. Let's say that 100 people plan a mountaineering trip to a very difficult mountain in the Himalayas. The protocol calls for establishing a base camp and then advancing to the summit. And let's say all 100 make it to the base camp, but only 10 make it to the summit, for whatever reason. How do we present the success rate of this climb? If we say that only 10 patients completed all the protocol and reached the summit, the success rate of people completing the protocol is 100%. If we take the view that 100 people intended to climb the mountain, but only 10 reached the summit, the intent-to-treat success is 10%. The number that is most instructive for subsequent groups of climbers and avoids the incorrect conclusion that the mountain is easy to climb is the intent-to-treat analysis. In a study such as ours, intent-to-treat analysis allows a true examination of a multi-step strategy. As with the mountain, some patients never make it to the summit, that is colonoscopy. In our study, the significant adenoma and cancer detection rate was comparable to other studies, but the overall adenoma detection rates in over 6,800 patients was low at 8%. This is an important point because another aspect of the multi-step strategy using stool DNA testing is the follow-up of patients with a negative test who should have a repeat stool test at 3 years because many of them will have undetected adenomas at the time of the initial stool test. We plan to study this in a subsequent study of the many patients who tested negative. A final word on why we screen. Should we be on a quest to identify colon cancer, hopefully at an early stage, or should we be using screening as a method to identify precancerous lesions that can be removed to prevent cancer altogether? These are discussions beyond the scope of our paper, but patients should make informed decisions based on all the options available to them.